Hi everyone and welcome to a special Ask the Experts webcast on prostate cancer, what you need to know. Now, on behalf of Prostate Cancer Foundation of Australia, thank you very much for joining us. So over the next hour, our panel will give you a bit of a prostate cancer 101. Everything you need to know about whether you're new to prostate cancer or are dealing with it, understanding things like what are the risk factors or treatments available and recovery. So for those of you who have registered, we've received your questions and I'll be able to put some of them to our expert panel tonight. If you are watching live, you'll have the chance to send through some questions and we'll be able to get to some of them as we go. So as we wait for more people to come online, let me introduce myself and the panel. My name is Ricardo Gonçalves. I'm a presenter on SBS World News, finance editor for the network, and I present a show called Small Business Secrets, and I'm really pleased to be your moderator tonight. Our panel includes, on my left, Dr. David Malouf. He is a clinical teacher at the University of New South Wales Medical School and is chair of the Department of Urology at St George Hospital. He is a lead clinician at the Complex Prostate Cancer Clinic at St George Hospital and is a visiting medical officer at Hurstville Private Hospital and St George Private Hospitals. He completed his urology training in Sydney prior to undertaking a fellowship year at the Hammersmith Hospital in London, specialising in surgical oncology and renal transplantation. We've also got Associate Professor Andrew Kneebone. He is a Senior Staff Specialist in Radiation Oncology at the Royal North Shore Hospital and Gosford Hospitals, as well as Genesis Cancer Care. He has nearly 20 years' experience as a prostate cancer specialist and is current co-chair of the National Radiation Oncology Genitourinary Executive and has been an author on multiple national guidelines for definitive and post-prostatectomy radiotherapy. We've also got with us Sally Sara. She's a prostate cancer specialist nurse consultant in the Southern Adelaide Local Health Network. She holds a Master of Clinical Nursing and has 30 years nursing experience across a broad range of specialty areas with a strong interest in uro-oncology nursing. And we've got Professor Simon Wilcock. He is a general practitioner and the Director of Primary Care at the Macquarie University Hospital. He was involved in the development of the PSA testing clinical practice guidelines. His education and research interests include the health of doctors, men's health and musculoskeletal medicine. So thank you all for joining us tonight.
Pleasure.
And thank you again for joining us. David, maybe we start with the basics. What is a prostate and what is prostate cancer?
Well, the prostate is a gland which is situated underneath the bladder. If you can imagine where it is relative to your skin, it's basically between your legs. It has a role during reproductive times. It provides a healthy environment for the sperm. And as you get older and you move beyond your reproductive years, its role becomes increasingly less relevant, but it starts becoming problematic, and prostates can become infected, they can become inflamed, they can become enlarged, causing urinary symptoms, and occasionally they can become cancerous. And I guess that's what we're going to be talking about today. Prostate cancer arises from prostate glands, and normal glands have a life cycle and they turn over and they die and new glands come along. But prostate cancer is when those normal control mechanisms start becoming a little crazy, and the prostate glands can keep growing, grow locally, and ultimately can spread to other parts of the body, causing problems. So it's a cancer like any other cancer in some respects, but in other respects it's quite unique in terms of many of these cancers grow very slowly. So we really do need to consider that it's a separate entity. And one of the challenges we have as clinicians is that when people hear the word cancer, they think they need an operation tomorrow or need an operation yesterday. And that's very much not the case when it comes to prostate cancer. And many men live with prostate cancer for years or even decades without coming to any harm.
And has the incidence of prostate cancers increased over time?
It has, and that's partly related to environmental factors, but partly related to the fact that we're all living longer. And to a certain extent, most men, if not all men, will get prostate cancer as they age. And I quote figures, 30% of 40-year-old men have microscopic evidence of prostate cancer. 70% of 70-year-olds, 100% of 100-year-old men basically have prostate cancer at a microscopic level based upon good quality autopsy studies. It's almost part of the ageing process, which is, again, one of our challenges, because clearly not everybody needs to be treated.
And Andrew, run us through what some of the risk factors are.
And as David's already alluded to, ageing is probably the most overwhelming risk factor that we have for prostate cancer. And then I think the second most important factor is the genes that you're born with. And it's well documented that people like African and black African men are twice the risk of developing prostate cancer and often can be quite aggressive. But also family history is incredibly important, what GPs like Simon would be looking at. And if you have a father with prostate cancer, you're probably twice the risk. If you have 2 or 3 relatives, you're probably 4 times the risk. And then there's actually hereditary prostate cancer, and the same gene that runs in several breast cancer families, the BRCA gene, can be the male affected relatives are at increased risk, and now genetic counsellors are now interested in the breast ovarian families as well as the prostate families. So they're the 2, ageing and genetics, and then we're starting to get into those environmental factors, and that's where we get a lot of controversy. There's issues, obesity, probably obese people are probably high at risk, and there's a lot of data and controversies about various dietary factors that might increase your risk. But that level of evidence is controversial, shall we say. And then a lot of people worry about the risk of sexual functioning, and there was actually a nice review article that said if you didn't have enough sex, then you're probably at a higher risk. And I showed that to my wife, and she said I better get screened for my prostate cancer. So there's a lot of controversies about risk factors, but overwhelmingly age and genes and family history are what's important.
Now, of course, upon registration, we gave you all the opportunity to get some questions sent through. So we'll go through some of those. First of all, in regards to diagnosis. So Simon, a lot of themes. First of all, can you run us through what some of the symptoms of prostate cancer are, especially those early symptoms?
Thanks. It's a really good question, and it's also a bit of a trick question because early prostate cancer more often than not has no symptoms at all, whereas some of the other conditions that David alluded to, having infection or inflammation of your prostate or just prostatic enlargement, which are all benign conditions, may well lead to symptoms. What are the sorts of symptoms we see in prostate disease, whether benign or less likely in many cases to be malignant? It can be local discomfort, local pain, irritation when you're passing urine or emptying your bladder. Certainly changes in bladder function is probably what men report most, particularly as they age. So the strength of the urinary stream, they may get urgency so that they, if they feel they need to empty their bladder, they need to empty it quickly. And they may also get problems with actually commencing micturition, what we call, or passing urine, what we call hesitancy as well. But it's really important for the population to know that none of those symptoms particularly suggest prostate cancer. Early prostate cancer, which is when we'd want to diagnose it, in fact, is more often than not asymptomatic. And that's why we talk about should we screen for an asymptomatic disease.
What about BPH and enlarged prostate? Can that lead to prostate cancer? Benign
prostatic hypertrophy, or BPH, or these days we talk about lower urinary tract syndrome, or LUTS, and people may have heard that acronym as well. That can certainly be associated with prostate cancer, but there's no clear relationship as far as I'm aware between the two. So again, they're both things that a GP should be considering and looking for, and they both have effective treatments, whether they're benign or malignant disease. And one of the things we have to decide is when treatment is appropriate and if it's actually needed.
One direct question we had, and anyone can answer this one. I'm interested in any current thinking on the hereditary aspects of prostate cancer. My father had it, I have it. What do my sons expect?
Well, as Andrew indicated, it is one of those cancers that does run in families, and the more first-degree relatives you have, the more uncles, father, brothers, etc., the higher your risk. And what is fairly clear, there's also some evidence that the younger you are, the younger your relative is, the younger you might be when you develop prostate cancer. So I'm always, when I'm talking to patients, very interested to hear about younger men whose fathers develop prostate cancers in their 50s and 60s because they are at risk of developing prostate cancer at a younger age. And what I think we need to be when it comes to prostate cancer testing is selective, and we try and identify those people who are at higher risk, and that includes men with family histories. And you start looking at those people at an earlier age, and you monitor them more carefully than you might, people without that family history.
Just another one we got to. I've heard that a lot of prostate cancers are not life-threatening or even uncomfortable, and that most men die of causes other than untreated prostate cancer.
I mean, that's the huge issue with prostate cancer today, isn't it? And as David said, when a man aged 70, the majority have prostate cancer in there. And so our job as clinicians and people involved in prostate cancer is work out which ones are harmless ones and which ones are the ones that need treatment. Because although it's very common, it's still the second biggest prostate cancer killer and the second biggest cancer killer in men today, and can cause major morbidity. And so we rely heavily on classifying men into low risk and high risk of dying from cancer, and the Gleason score is something that we'll probably talk later about, the biopsy results, the PSA level, the degree of elevation, and what you can feel in the size of the mass in the prostate. So that is a huge part of our work.
Before we get to PSA, Sally, and we're talking about diagnosis, Sally, you often sit in when patients are diagnosed. So can you tell me about that?
Sure. So as a prostate cancer specialist nurse, that's really where my role starts. So I sit in on those consultations, and sometimes men are with their partners or families, and sometimes men are on their own. And I'm quite conscious that some men will be expecting a positive result. They've done a bit of research already, and they've had a biopsy and they're thinking this is going to come back positive. But quite a number of men, even though they've had the biopsy, they have no symptoms, they feel fit and healthy, and they're really not expecting the word cancer to come out. So I do a lot of reading of the situation. And then I watch the body language. Now, that 15-20 minute consultation, quite often a lot of that's not remembered afterwards, particularly if the man is on his own and is not expecting those answers. I make sure that when the man goes home that day, that he's got some good evidence-based information to take home with him. And in fact, in that consult, I have it on my lap, and as the doctor's talking, I fold corners of the pages over and put circles around things and write specifics down. So even if not a lot is remembered from that actual 15-minute consult, when the man goes home, he goes to tell his family, there's something to refer back to. The other thing I do is make sure that we have a discussion about support and resources and a return date, or make sure he has my number to contact if needed, and really a discussion about what happens next. So that's, for me, or for me and my colleagues, that's the beginning for us, and then we become a point of contact from that point onwards for those men.
I'd just like to reiterate, it's incredibly important to have a support person there when you're being told you have prostate cancer, because the amount of issues, the amount of information that is portrayed over a relatively short period of time is huge. And having if you're getting a biopsy result, make sure that you have someone there to hear what's been spoken to.
And I guess, David, to put all of that into context then, run us through how prostate cancer is actually detected then and diagnosed.
Well, the majority of the men I see haven't been diagnosed with prostate cancer. They might be referred by their general practitioner with an abnormal blood test, an abnormal digital rectal examination, or sometimes both. And it's often the urologist who will discuss with the patient the implications of those abnormal findings, the role of a biopsy, potentially the role of imaging before the biopsy, and we're increasingly using MRI prior to a biopsy to help make a diagnosis. And the biopsy itself is either done under a local anaesthetic or a general anaesthetic, and it essentially involves an ultrasound in the backside which guides a needle into the prostate, and we take samples of the prostate, usually throughout the entire prostate, and the pathologist will look at that over the next few days under a microscope and determine whether A, is there any cancer present, B, what is the volume of that cancer, and C, what is the grade of that cancer. And the grade's relevant because, as you said earlier on, some of these tumours are low grade, they're low risk or indolent. I call those the kittens, and they often don't need to be treated, but the tigers, the ones that will cause problems if they're allowed to grow, they are the ones that do need to be treated. Once a diagnosis of prostate cancer is made, typically you would have some staging investigations to confirm that the disease is only in the prostate and it hasn't got outside of the prostate, and then a discussion will be had with the patient as to whether treatment is necessary, and if so, what's the best treatment for that individual patient. But I'd reiterate what was said earlier, that nobody should be expected to make a decision about treatment options at the same time that they're getting a biopsy result. In my practice, I think in most people's practice, it's a 2 or even 3 consultation episode to advise of the findings, have a preliminary discussion about what it means, what the options are, and then I encourage people to come back with family members, having read some material, and 2 or 3 longer consultations to help that patient make a decision regarding treatment. And it's a very individual decision. There are treatment options, and men need to be aware of those options and have ample opportunity to discuss what's best for them.
And final question before we move on to PSA, and I do acknowledge we've received some live questions on that. How important is diet to keep prostate cancer at bay?
Simon, do you want to have a go at that one?
Look, as far as I'm aware, there's not a lot of evidence about specific diets. There's certainly a lot of claims made. What we do know is that obesity significantly increases the risk of many common cancers in the community, and we think that that probably applies to both breast and prostate cancer as well. And it's thought that currently in Australia, up to 30% of all cancers are related to being overweight or obese. So in terms of eating a healthy diet, eating well and managing your weight and including exercise in your lifestyle, those things are important. I'm not aware of specific diets that will protect you against prostate cancer, but the others may comment.
I think there's reasonable evidence out there that a healthy heart diet is a healthy prostate diet. And that makes it easy for patients, because you go into the supermarket, you see how many heart ticks it's got, or little hearts for healthy diet. And I encourage patients to have a balanced diet. Specifics, avoid overcooked meats. That's an association. But basically, a healthy heart diet equals a healthy prostate diet.
Okay, let's talk about PSA. First, go straight to a live question that we had, and it's directed to you, Simon. And they want some information about the PSA blood test as part of diagnosis, and can the digital rectal examination test be performed by a GP, or does this have to be conducted by a specialist?
Thanks. They're both excellent questions, and I think probably the responses to those questions would have varied quite a lot over the last 30 years or so as our understanding and tools have changed in that time. First thing to say about PSA is it's like all of the tests that we order as a GP. It has its strengths and weaknesses. One of the weaknesses is that we'll never diagnose prostate cancer with a PSA. It's not intended to do that. It's intended to give an indication of the volume of prostatic tissue in a body, and certainly if it's very high, there's a high risk that you may have prostate cancer. But in the majority of cases where we're using it to screen for the possibility of prostate cancer, what we'll see is that it's an abnormal level, but that may be associated with a number of things, including benign enlargement of the prostate. So for what it's designed to do, it's actually quite a good test, and far better than anything that we had up until it came into place 30 years ago. We'd obviously like a more specific diagnostic tool just for prostate cancer, and there are a number of tools that are being looked at the moment, but not yet readily available. The other question, the other test you were asking about, just
it was in regard to whether a digital rectal
rectal examination. Again, there's been a lot of controversy over the value of digital rectal examinations. When the NHMRC group looked at the literature associated with that, it was hard to make a definitive recommendation that a digital rectal examination should be part of an effective screening program in asymptomatic men for detecting prostate cancer. That said, most of the patients I see as a GP, I'm not just looking at looking for prostate cancer. I'm looking at their health generally, including their prostate health as they age. And I would still consider that performing a digital rectal examination in a comprehensive health assessment check for any male patient over the age of 50 is a very reasonable thing to do in consultation and acceptance by the patient themselves, because you're assessing the size of the prostate. There's certainly evidence that occasionally you'll find abnormalities or irregularities that may warrant further investigation and may not be associated with an elevated PSA. But again, be interested to see what my specialist colleagues think of that.
before we get to that too, and while we're still talking about PSA, because we had a lot of questions about the PSA guidelines and Gleason scoring as well. Can you go through that?
Yeah. Gleason scoring is very complex and complicated, and I went to a presentation earlier this year by a pathologist who spoke about it, and even she said she had difficulty sometimes understanding particularly some of the new classifications of Gleason scoring. But I think for the layman and for myself as the GP, the important thing to understand is that when prostatic biopsies are taken and analysed, and as we've heard, often multiple biopsies will be looked at, there's the pathologists look not just for the commonest form of abnormality or in the case of cancer, cancerous cells, but also for the scope and range of cancerous cells that may be there. David described the natural history and evolution of prostate cancers through a person's life, so it's not unusual in biopsies to see things that may look like a very mild form of abnormal cell or a very early cancer, but also in the same person in a different biopsy there may actually be quite advanced cancers or more worrying cancers as well. The current approach to Gleason scoring, and it has changed and is now also associated with another terminology called grading, is to report on the variety of cells that are there, and to present that to the person who's going to make a treatment decision, which in this case will be the urologist, in such a way that they can categorise what's going to be the most effective option, whether it be to do nothing and observe, or what sort of treatments might be indicated for this patient.
Andrew and David, keen to get your take on PSA testing.
Hey, yeah, so PSA is a blessing and a curse in prostate cancer management, and PSA has a lot of limitations, and some of the nasty cancers don't produce PSA, and some benign enlargement can produce quite high levels of PSA. So there's a rough rule of thumb that PSA more than 4 is abnormal and should be screened for prostate cancer. But a person who is 48 with a PSA of 3, that's a real worrying PSA level, and that should be investigated. So the PSA should be age-specific, should be related to the size of the prostate, and we call that the PSA density. A large prostate would be expected to have a higher normal PSA. And then we also want to look at PSA velocity, how it's changed over time. So a significant rise in a PSA over 12 months is of concern, whereas very slow rise is reassuring. And then there are other tests and nuances in a PSA. We call it the free to total ratio. So you can work out the amount of PSA that is free in the system and not bound to proteins, and a lower ratio, less than 10%, can often indicate cancer. So the PSA is complex. It's not just for higher cancer. It needs to have a good discussion with your general practitioner to say, look, that result for you I am uncomfortable with.
I think PSA can be used in 2 scenarios. It can be used to identify people who need to, in the screening situation or the testing situation, and identifies those people who are at risk of prostate cancer. And it also can be used to monitor response to treatment. So looking at the first scenario, I say to patients, a PSA is like the red light, the warning light on your dashboard. It comes on. What does it mean? We don't know what it means. We need to work out what it means. We need to diagnose what's wrong with the engine and potentially fix whatever the problem is. So, as we said earlier, most people who have an elevated PSA don't actually have prostate cancer. They've got, it's either, it can be elevated because of some acute viral illness that they've had. And I mean, that's a very important point. I think most people that have a PSA which is abnormal, the first thing to do is to repeat the test. Because around about 30 or 40% of the times, if you check that PSA 6 weeks later, the result will be back to normal again. They don't need a biopsy. They don't need any further investigation. Where the PSA is persistently elevated, they're the group of people that you need to have a look at. Do they have an enlarged prostate? Do they have an infected or inflamed prostate? Are they at risk of prostate cancer? And by having those discussions with patients, you can determine, do they need further investigation, and what should that investigation be? The second role of PSA, it's actually very accurate. It's measuring response to treatment. And for example, if you have radiotherapy or if you have a radical prostatectomy, we would expect your PSA to fall. And if it reaches what we call the low point or the nadir, and then it starts to rise again, we get concerned that there might be a recurrence of prostate cancer. So it's important to consider the use of PSA in monitoring responses to treatment as well.
And Sally, I understand there's something called PSA anxiety. Is that right?
Yes, that is correct. There's a phenomenon called Perce Anxiety, and it's quite well represented in the literature. And I certainly see it firsthand. And it is, as David was saying, it's after treatment has occurred. Really, it's the surgery, radiotherapy, or hormonal therapy, or even chemotherapy. A line is drawn in the sand, and it takes on a new meaning after there's been a treatment given. And I warn men and their families that when they, particularly in the early days, when they start having their routine checkups after treatment, that they'll be quite anxious waiting for those results. And one of the thoughts is if you're having a six-monthly checkup with a PSA check, don't have it done a month before and then worry about it every single day. Have it done a few days before. And also remember that PSA anxiety, it doesn't just affect the man himself, it affects his partner, it affects the family, and just to be kind to each other and know that you know, when you come into that consulting room, that's one of the first things that'll be raised, because we know that that's what men want to hear. What was the PSA result? So it is talked about quite a lot in research. You just have to be aware of it and expect it and manage around it. And I think over time, for many men, they get used to that. But you know, this having the PSA checked after treatment will go on for a very long time.
And the final question before we move on to our financial costs, and this can go to anyone, are there any other developments of blood tests other than PSA?
I mean, and we need a better test than PSA. We all recognise that. And there are a few commercial products available called the Prostate Health Index, or the PHI. And there are other tests that are trying to do better, but they're still imperfect. And at the moment, I think 99% of urologists would, or GPs in screening would do a PSA. You get a free to total ratio, look at the velocity, look at the change in time, correlate that with the rectal examination findings to make the decision whether this needs evaluation further. So I don't think we're using many of the other tests available, are we, David?
I think there's a lot of work being done. I think genetic testing is where that's the holy grail. I mean, if we can actually take a prostate cancer cell and determine, look 10 or 15 years into the future, is that going to be an aggressive prostate cancer, or is that going to be an indolent prostate cancer? That's going to help us make decisions whether people need active treatment or whether they can be monitored. But I think Andrew's right. PSA testing, it's the best test we have at the moment, and when used appropriately, it is a good test.
Okay. We also had some questions upon registration on financial implications. One of them, is there any progress on Medicare or private health covering expensive tests, including MRI and biopsies?
The answer is yes, there is progress, but it's slow progress. It's like anything in medicine. If a new technique or a new treatment comes to light, then before the Department of Health is going to start paying for it, it needs to be evaluated. And there's a formal process. It can run for 2 to 3 years, the process of evaluating new treatments. It's like new cancer drugs which come onto the market, new melanoma drugs. There is a process to evaluate the effectiveness and the cost effectiveness. And I would say that we're about 80 to 90% of the way down that pathway to saying, yes, MRI is a useful tool for prostate cancer. Yes, there should be reimbursement through the Department of Health and Ageing for MRI in this scenario. So I don't want to put any timelines on it, but I'd be optimistic within the next 12 to 18 months that there will be a resolution of this, and the MRI will be widely available and Medicare rebated.
Simon, I can see you nodding there.
Yeah, and David's quite correct. I mean, unfortunately, there's often a lag between what we in clinical practice perceive is going to be very useful and a sort of a catch-up of the evidence, but also then convincing the funders, and these things can be expensive, to fund particular tests or therapies. I think the evidence there for MRI is that if we have a better tool for assessing the prostate along with biopsy, and sometimes an MRI will obviate the need for for biopsy, that may actually, even though the MRI itself is potentially expensive, it may obviate the need for very expensive therapies and treatments and investigations down the track. So like David, I'm very confident. I think this is something that, it's becoming a no-brainer that it should be part of our diagnostic armamentarium, and it's just a case of, when we can already refer patients, they can't access Medicare through it at the moment.
Okay, I'd like to spend a bit of time right now also on treatment. Andrew, what are some of the different treatment options available?
Yeah, so whenever a person is diagnosed with prostate cancer, the most important first step of treatment is to treat or not to treat. And basically speaking, low-grade cancer, low-volume cancer, and the age and health of the patient all put into an algorithm, we often recommend a process called active surveillance. Seeing if it's biologically an aggressive cancer, that if it grows and progresses over time, that can potentially be a threat, then we recommend treatment. And then there's a subgroup of patients that you say, crumbs, they need treatment. They've got a significant proportion of higher grade, it's grown into a lump, the PSA is markedly elevated and growing more quickly. You want that cancer out of the body. So they need to be staged. We can talk again about better ways of staging with MRIs and PSMA scans and all these sort of things, but then the two broad groups of treatment that you can be treated with are either surgery or radiation. And just to make life much more complex, there's so many different types of radiation, and becomes like the arms race. Some people have got brachytherapy, some have got proton machines or VMAT machines or some cyber knife, and so it becomes very confusing, the different types of radiation. And even surgery, there's laparoscopic, open, robotic, and so this is what has become the huge dilemma for patients wading through the treatment options that are available to them, and getting support through that processes. And that's PCFA has done a wonderful job trying to collate books and get information, but it's the real challenge for patients today.
So how do you decide on the right treatment?
I spend quite a lot of quite a lot of time in that space with the men that I see, and whilst it's not my role to sway them either way, it is my role as a prostate cancer specialist nurse to make sure men have the right information and good evidence-based information to support them to make that decision. And one of the things I say is, when you go back for that appointment where you are going to discuss the treatment option, make sure you take somebody with you, someone who can write notes, go in prepared with the questions that you need to ask. And some of those questions are, what are the options suitable for me? When do I actually need to make this decision by? How much will it cost? What are the pros and the cons, the side effects? Sometimes it helps to write a pros and a cons list and with family, and often I find men eventually, when they make their decisions based on the treatment with the side effect profile that they're most comfortable to accept. For some men, making the decision is almost an impossible task, and in that setting I'd recommend getting a referral to see a psychologist to help with that decision-making process if it really becomes a problem.
I spend quite a lot of my time in the office trying to talk patients out of treatment. There is a very large number of men diagnosed with early prostate cancer, perhaps as high as 40%, who do not need treatment, who do not need immediate treatment. Simon mentioned that we're in this transition phase from Gleason to grade grouping. We're trying to make it easier for patients to understand that not all prostate cancers are dangerous. And if you're diagnosed with a grade group 1 tumour, which is the old Gleason 6, the vast majority of those men don't need to be treated immediately. And that's really important. As I said earlier, people hear the word cancer and they assume that they need to be treated yesterday. Prostate cancer, in many respects, is part of the ageing process. Like wrinkles on your skin, it just happens as you get older. And not everybody needs to be treated. And if you've got a relatively small volume of a low-grade tumour, a grade group 1 tumour, you might not need treatment now, you might never need treatment. So as Andrew said, you've really got to determine through consultation with your urologist or your radiation oncologist and your GP whether you need treatment. And sometimes I encourage people to get second opinions. I think taking some time, seeking a second opinion, be it from a radiation oncologist or another urologist, is a very useful exercise because sometimes you hear a different perspective on the same story, and it just helps crystallise in your own mind what the pros and cons are. And I think Sally's right. Where treatment is required, there really is no good evidence to say that surgery is better than radiotherapy or radiotherapy is better than surgery. I mean, that's an argument that's been going on for 100 years and will rage for another 100 years. But at the end of the day, I say to patients, well, if the outcomes are very similar, how are you going to make a decision? We need to discriminate between treatments on the basis of the logistics of treatment and the side effects of treatment. And that's where there are differences, and that's where patients can actually, there's some hard and fast information that they can digest and say, well, the worst thing I can imagine is leaking urine after an operation. I'm going to have radiotherapy. Or I'm particularly interested in maintaining sexual function. I'm going to have brachytherapy. There are different treatments have a different side effects profile, and that's really how patients should approach it.
I'm so glad you brought that up, because we've got 2 live questions that have just come through, one on surgery and one on radiotherapy. The first one is a question that's been directed to Dr. Kneebone, and this person would like to know your opinion on radiotherapy, brachy, low, high dose, and EBRT for young patients, for example.
Yeah, so it's such a huge, broad sort of area. And so for young patients, we, as David said, we tell patients that for the majority of cancers, your chances of being cured are very, very similar, whichever pathway you go down. And so for a young patient, then you really need to go through the radiotherapy options. You can say there's brachytherapy, which is only suitable for good prognosis where there's unlikely to be roots outside of the prostate, but that can be a day-only procedure. Brachytherapy needs to be done by people with real skill, and there's actually only a relatively small handful of units that really are proficient at brachytherapy. So you need to see someone who's got expertise in that area, and in good hands, brachytherapy results are outstanding, but they're a relatively small subgroup of patients. And then in terms of, as David said, the profile, you know, if you're 75, you're diabetic, carrying a bit of weight, but you need a cancer being treated, then I think radiotherapy is a better treatment approach. If you're 55 and you've got problematic urinary function, and you can have an operation, be out in 2 days, restore your urinary function, that would probably be a better approach. So it really needs to be tailored according to a person's circumstance and the fear of side effects and their circumstances in life. So there are many different options. Brachytherapy, when we said the other part of the question was giving high dose rate or following external beam radiotherapy can be a very nice way of giving extra dose to a lump that you're really worried about. So many different techniques, and needs to be tailored according to individual circumstances.
And the other live question that we received earlier, and this can go to anyone, it's about surgery and it's quite broad. How soon after surgery can a person be assured of being cancer-free?
What we routinely do, 6 to 8 weeks after the operation, we'll do a PSA test. And following a radical prostatectomy, following surgical removal of the prostate, we really, if the cancer has been completely eradicated, the PSA should drop to an undetectable level. Now, what does that mean? It used to mean a PSA of less than 0.1. Typically now we talk about PSAs of less than 0.01. The lower the PSA, the better. But a PSA should ideally is undetectable. If there is still measurable PSA in your bloodstream 6 to 8 weeks after the operation, you've got to start asking why. Has the cancer not been completely removed? Are there other treatments going to be necessary? Sometimes we'll follow up a radical prostatectomy with what we call radiotherapy. That can be given early, that can be given late. There's lots of different combinations. But to address your question, a PSA 6 to 8 weeks after the operation is usually a very good indication of the success of the surgery. Now, sometimes we see a situation where the PSA is undetectable and then it starts to rise many months or years down the track. That, unfortunately, is usually a sign that there has been some recurrence of the prostate cancer, and then you move on to the next chapter of the treatment book. And you know, this is a book which is just getting longer and longer because people are coming up with more and more treatments. And in many respects, I remember hearing that breast cancer diagnosis was now a chronic illness, and there's a 15 to 20 year program of treatments, and prostate cancer is becoming increasingly the same. Just because you don't cure it the first time round doesn't mean that we give up on the patient. It is very much it's a long game, not a short game, managing prostate cancer.
And just maybe add just an extra little comment is, one, the 5-year survival both following surgery and radiation for all people who are treated is now more than 95%. So we're doing well. But we have to recognise that almost 25% of people following surgery or following radiation will ultimately relapse from their cancer. And that relapse can be many years down the track. And that's why Sally was referring beforehand this PSA-itis, worried about your PSA. And people with prostate cancer can be a very slow-growing cancer, need to be followed up over a long period of time. So there's no way that at 6 weeks after treatment, they look at you and say, am I cured, doc? You can offer them that reassurance. They need to be followed up over time. And, you know, that's the same with all cancers.
And David, you were mentioning how there were more and more treatments coming up. So Andrew, my question is, what are some of the advances that you're expecting in the next 10 years?
Yeah, and we're really in exciting times with prostate cancer management. We've already alluded on to better imaging with MRIs for staging cancer, for assessing cancer. There's now a new nuclear medicine scan called a PSMA scan, prostate-specific membrane antigen scan. And for us, that's a game changer. That can detect a 4mm lump of cancer. So for staging cancer, assessing its risk for relapse of cancer, that's been a huge breakthrough to be able to identify spread of prostate cancer. David's mentioned earlier the biology. We agonise over whether cancer needs treatment. And we are very, very close to getting some of the cancer tissue, do a genomic analysis and say that cancer's harmless, don't worry about, go to the Bahamas, and this cancer needs treatment. So the biology is really, we are so much on the cusp of being able to better stratified treatment approaches. And then treatments have improved light years in terms of improving quality of life, effectiveness of treatment, and then that leads on to survivorship. We have more than 200,000 prostate cancer survivors in Australia at the moment. 95% 5-year survival means many people are here coping with the rigours of prostate cancer treatment. So improving their control, their sexual functioning, their bowel functioning, their quality of life is a huge area where we need to address.
While we're talking treatments, another live question that has come through. Can the panel comment on the question that does brachyradiation over time leave you more prone to osteoporosis, and or does the same treatment have an effect on one's immune system?
Yeah, so that's one of the attractiveness about brachytherapy. It's very localised radiation treatment, so it doesn't travel through the hips, and the radiation is confined to the prostate. So very low risk of osteoporosis and all those effects, which can be more related to hormonal therapy. In the old days where radiation used to go heavily through the hips, that used to cause osteoporosis. So brachytherapy, that's one of its attractiveness, that it reduces those long-term risks.
And one more very quick one, again to you, Andrew. I have heard that if you choose radiation treatment, and this is a live question that we received, and it fails, you cannot then have the prostate removed. Is this correct?
Yeah, no, so surgeons like David hate operating after radiation failures. Yeah, a skilled surgeon like yourself, it's a walk in the park, but it's a much more challenging operation and higher risk of complications, and you only do that in patients that are fit and well enough, because people might take 10 years to relapse. So it is a more challenging procedure, but what I try to tell patients is that your chances of being cured are often very, very similar if you go down the surgery pathway or the radiation pathway, and cancer only coming back in the prostate after radiotherapy and nowhere else is a relatively uncommon phenomenon.
Yeah, I would echo those sentiments. I say to patients, don't make a decision based upon a very unlikely contingency. I mean, if you have brachytherapy or you have radiotherapy, the likelihood of the prostate cancer coming back in the prostate itself, where the treatment's been, is actually very uncommon. So I say to patients, you choose your primary treatment based upon the risks and benefits and the side effects of that treatment. If it doesn't work, there is a plan B, there is a plan C. You can undergo a salvage prostatectomy. It is more complicated, it does carry a few extra risks, but the reality is it's very rarely required, because most people do not relapse locally in the prostate after radiotherapy.
With all this information, Simon, what do you tell your, patients when they come to you as a GP and they hear about all of this?
And again, an excellent question, because in the days of eye technology, patients can access information from multiple sources, some of them very valid sources and some of them quite dubious sources as well. I think the things that Andrew and David have spoken about are both very important, understanding the risks and the potential side effects and helping patients to decide which of the things that they're more comfortable with. But I think also, as a GP, I would emphasise choosing the operator or the therapist that they're comfortable with, I think David referred to many cancers these days, including prostate cancer, as a chronic disease. This is something that you may live with for 20 or 30 years, and with life expectancies having gone up by a decade and 25 years, that's often the sort of lifespan that we're looking for. And that you need to be working with somebody who you're comfortable with, who you trust. The fact that there are multiple treatments available tends to emphasise, as these guys have said, that one isn't particularly a whole lot better than the other. Otherwise, we wouldn't be doing the other anymore. But you do want to be working with somebody who you trust, who you have a good rapport with, who you're going to be able to communicate with when and if things change.
Okay, let's move on now to our side effects. David, one for you. What are some of the side effects of the current treatments, and how can you best manage them?
Well, the side effects will vary depending upon the treatment that a man chooses, and this is what really does distinguish one treatment from another. If you look at surgery, for example, even the best of hands, I mean, men often experience incontinence, at least almost all men have incontinence to begin with. Most men regain their continence over a 3 to 6 month period with the use of pelvic floor exercises, but there's a core group of 5 to 10% of people who do not fully regain continence, and many of those men may go on to have further surgery to correct their continence. The younger the patient, the fitter the patient, the more proactive they are with pelvic floor physiotherapy, the better they get. But there is always going to be a core group of patients who do have problems with stress incontinence after surgery. The other big one is erectile function. And if you're dealing with men who are in their 70s and 80s, for some men, sexual function is less relevant. For most younger men, it is very relevant. And there are ways and means of performing the surgery which minimise the risk of erectile dysfunction. But I think most men need to go into surgery expecting to have some impact upon their sexual function, and certainly an impact upon their ejaculatory function. And it's not just a case of whether you get an erection or not. Sexual function is a sort of factorial process. And I think having a discussion with the clinician, the physician, regarding what's the most likely outcome for me, is very important. I mean, I see a lot of men, unfortunately, who have had prostate cancer treatment, be it surgery or radiotherapy, and down the track they do have incontinence, they are impotent, and they start questioning whether they made the right decision from the beginning. And I think taking your time after a diagnosis, not rushing into treatment, considering all of the options, minimises that regret that unfortunately a lot of men actually have.
I guess sexual function was one related question that we received a lot on during registration, and I guess one, for example, was saying they had some concerns about erectile dysfunction and shrinkage after surgery, and the question is, how common is it, and is there anything that can be done about it?
Look, sexual function related to surgery, again, there are lots of factors that come into sexual function. The most important factor is, what are your erections like to begin with? And if the erections are already fairly ordinary in your late 60s and you have a radical prostatectomy, unfortunately the erections are not going to get any better. They're probably going to get worse. The other key factor is it relates to the nature of the surgery, the template of the surgery. There are two nerves that run very close to the prostate. We call them the neurovascular bundles. And if you've got cancer close to the neurovascular bundles, the most important thing is to get all the cancer out, or to try and get all the cancer out. And occasionally we have to do a wider dissection around the prostate, and those neurovascular bundles, one or both, might be sacrificed. And normal erections after a wide excision is very uncommon. Now, there are ways and means of recovering sexual function. Some people respond to Viagra, some people respond to injection therapy. Penile implants are very good after the event. I think fundamentally you need to make sure that you do the best treatment focused on getting rid of the cancer, but also at the same time consider the side effects. I mean, Andrew might want to talk about radiation side effects as well. I mean, all treatments have side effects. Our job is to try and minimise those side effects and minimise the impact of those side effects on the patient.
Yeah, Andrew, what about those related side effects with radiation?
And I think it's important to reassure people looking at this sort of pathway that we're getting a lot better. And things have really changed over the last 20 or 30 years. And the Cancer Council has done quite large surveys of survivors from prostate cancer, and their global quality of life is very close to the normal population. Urinary troubles are a lot less than what they used to be. Surgery sure can reduce urinary control, but radiation can cause irritation and frequency and sometimes bleeding, and I think the urinary quality of life is often very similar 5 years down the track. Radiotherapy on its own probably has better erectile functioning in the first year or two, but with a good nerve-sparing procedure, it's often the same 5 years down the track. And in many cases, we have to give radiotherapy with hormonal therapy, which could have an immediate detriment to sexual functioning. And indeed, some of these surveys have really shown that the thing that hits men most 5 years down the track is actually the loss of erectile functioning is the thing that men miss most. And their urinary and bowel difficulties are often very manageable. So, and it's interesting, David Smith just told me a 10-year update, and by 10 years, men are much more accepting of the loss of sexual functioning. So it's something that you do get used to over time, but can take a little while.
So, Sally, one for you. How can patients then manage some of these side effects?
Well, it depends on the side effect itself, and certainly David and Andrew have talked about managing the physical side effects after treatment, particularly the urinary and sexual and bowel type side effects. Also side effects from medication as well, so hormone therapy or androgen deprivation therapy as we call it. Certainly a range of side effects there in terms of hot flushes, weight gain, osteoporosis, and in that setting I think it's really important to have a good GP who manages that whole range of side effects there, because often the hormone therapy is long term, and the use of allied health professionals, which can be accessed through private health insurance or through a chronic disease management plan through a GP. So bringing in exercise physiologists from an exercise point of view, dietitians, physio, pelvic floor physios, psychologists. And really there's been quite a bit of focus on the physical side effects, but I think it's also important to acknowledge the emotional side effects from treatment as well, and they often go under the radar a bit, and those side effects can sort of pop up sometimes years down the track, and it's very common for men to feel worry and fear and anxiety and distress. Really, it's about acknowledging that distress is a normal human experience, and when there's significant distress, the referral to a psychologist as well. Psychologists are really good at helping find ways to manage that distress. Also being aware of the other resources that are out there in the community through the Prostate Cancer Foundation and the Cancer Council. Cancer Council run a really good Living Well After Cancer program for up to 5 years after cancer treatment. Prostate Cancer Foundation have the support groups and also the online community forum, which is a great avenue for men to get online and chat to other men about their experience, and families and partners as well about their experiences. So really, I mean, you could have a whole session on managing side effects, but it depends on which ones are the most distressing at that time, and finding where the resources are to address them.
I'd just make 2 points. First of all, we are actually getting better at treating the prostate cancers, but we're also getting better at treating the side effects. And I get distressed when I hear about men who are quite wet, who are just wearing incontinence pads. There are ways and means of addressing post-prostatectomy incontinence. There are ways and means of addressing erectile dysfunction. So if the patient or the family members feel that their loved ones are living with side effects and those side effects are very debilitating, there are things that can be done. And you either talk to your urologist or your radiation oncologist, or you talk to your GP, and if you're not making any headway, you see another urologist and get an opinion, not just about the treatment, but about the side effects of treatment. And the second point I'd like to make is that, and we're almost back to where we started, the treatment with the fewest side effects is active surveillance. The treatment that is going to have the least impact upon your quality of life is doing nothing. So if you are fortunate or unfortunate as it might be to have a prostate cancer that does not need to be treated, consider active surveillance. It's a very valid treatment option, and that's the treatment option that's going to give you the best opportunity of maintaining those quality of life parameters that you were talking about earlier.
And I just wanted to quickly make the point that men have time to make a decision. There's good data that you can wait 6 months before having definitive treatment without compromising your long-term outlook at all. So please do not feel pressured to make a decision right away. And the second point is to say, look, I think there's a lot of sense in getting another opinion if you feel at all uncomfortable with the opinion that you've been given. And so if you see a urologist said you need to be operated tomorrow, you say, look, you have time to see a radiation oncologist, talk to your GP, get supports and get the information and know what you're dealing with. I think that has to be such an important take-home message.
We've still got a little bit of time to focus in on more detail about support. So, Sally, can you tell us more about, how you help support patients make decisions about treatment? And again, on top of that, one related question that we had during registration, someone said, just diagnosed, confused and nervous about deciding on which treatment option. What support services are available to assist me?
I think in that setting and for that gentleman, the first step of all is to make sure there's access to the medical team to talk to. So if he's had an appointment already with a urologist and he's unsure, speaking to a GP, speaking to someone like myself, having good evidence-based information. Not everyone has access to a prostate cancer specialist nurse, and at the moment it's about one in 4 men diagnosed have access to a nurse like myself, which is one of the reasons why the Prostate Cancer Foundation have an excellent set of resources that are all available online, or you can phone through and they can be posted out to you, and they have explain in very simple terms what treatment options are out there, the pros and the cons. And I think also to reiterate what you've said, that you don't have to rush into this decision. And it's a reasonable question to ask, how long can I take to make this decision? So evidence-based information, family support, take someone with you to the appointments, look at the pros and the cons, and take the time you need to make the decision that's right for you.
We've got about 30 seconds each for a bit of some final pieces of advice. Maybe, Simon, if we start with you, what's some final advice you can offer anyone going through prostate cancer?
We've reflected on the fact that people are living much longer, and if your prostate cancer is diagnosed at, say, age 60, your life expectancy is around age 85. And as people age, they develop other chronic diseases, and that's a normal part of ageing. So I think the important message for people is to feel that they're going to live with their prostate cancer just as they're going to live with other ageing-related problems such as osteoarthritis, and to make sure that they've got an effective team of healthcare professionals, and these days no one professional can manage all of their problems, and make sure they get the support that they need.
Sally?
I 100% agree with everything you said. I think being aware, accessing resources, also acknowledging that whilst prostate cancer is a disease for men, it is a disease that affects whole families, partners, families, friends, and it's important to acknowledge the support team. And for men who don't have a support team, there are support groups out there and who will help you through this process as well. So be informed, really.
Andrew?
Yeah, I'm just sort of saying to everybody that the world of prostate cancer management is changing majorly, and there's new developments, new advances all the time, and it's really quite exciting from our perspective. And I would just encourage anybody who has someone affected by prostate cancer to make sure they see a prostate cancer specialist, get a second opinion if they're at all uncomfortable, something's not fitting right, and they have time to make a decision and make the best approach and see the right person is incredibly important.
David, final thoughts?
Final thoughts. I think some people feel pressured into making decisions about prostate cancer treatment. There is no such thing as an urgent radical prostatectomy. Take your time, read the PCFA reading material, read the Cancer Council reading material, and seek a second opinion. There are some very good public hospital treatments. Just because you're not in a health fund doesn't mean that you're going to get second-rate treatment. We have some excellent public hospital facilities around Australia, and wherever you're treated, in the public system or in the private system, find somebody you're comfortable with and take your time to make a decision regarding your treatment.
Okay, well, that wraps up our Ask the Experts Webcast, proudly sponsored by Astellas. Thank you very much to our panel, Dr. David Malouf, Associate Professor Andrew Kneebone, Sally Sarah and Professor Simon Wilcock. And thank you for you logging on. We do hope you have found this information useful, and don't forget Prostate Cancer Foundation of Australia, the website. It has plenty of information there for you and resources to gain even more knowledge. I'm Ricardo Gonçalves. I'll see you next time.